Pleasure, particularly for IPCA Laboratory. I invite you particularly for today's our program Experts Outlook series. The eminent speaker Dr. Abhishek Karmarkar. The topic particularly for beta blocker in hypertension with heart failure. So I welcome Dr. Abhishek and our chairperson in this program, Dr. Chandrakant Upadhyay. He is soon, I think, some technical issue. Soon he is joined the program. So over to you, sir. Please start, Dr. Abhishek.
Thank you very much for the opportunity. Uh, the topic for the today is the role of beta blocker in the management of hypertension, especially in the heart failure. So we are going to look at the historic aspects, then indication, controversies, type of beta adrenergic receptors, heart failure in India, and then few trials, guidelines, and summary. This is the initial journey of beta blockers since when they were discovered and how it went on. So there were a lot of controversies about beta blockers. Initially, they were the drug of choice for hypertension. Then again, it was withdrawn because of the mortality controversy regarding the mortality benefit, etc. And now again, they are coming back with, especially in patients with ischemic heart disease and patients with heart failure. So look at the history now. Beta blockers were first developed by Sir James Black at the Imperial Chemical Industry in UK in 1962. He published his first work on beta blocker in the year 1958. 30 years later, Sir James Black was awarded Nobel Prize in 1988 for the advances in medicine. So let us look at the action of beta blockers. Beta blockers block the action of endogenous catecholamines, that is epinephrine and noradrenaline, on the beta adrenergic receptors. The sympathetic nervous system mediates the fight or flight response. This was evolved over the million years. Prolonged excess activity causes disease, and beta blockers are used to treat these disorders. So, beta blocking effects are negative chronotropic, negative dromotropic, antiarrhythmic, negative inotropic, anti-ischemic effects, and there are few interactions, as in nodal depression can be added by other antiarrhythmic agents like verapamil, diltiazem, digoxin, etc. And calcium channel blockers and antiarrhythmic may cause additional, negative inotropic effects. So when we combine these drugs together, we should be cautious. Indications for the beta blockers. These are basically angina pectoris, myocardial infarction, heart failure, atrial fibrillation, cardiac arrhythmias, symptomatic tachycardia, hypertension, MVP, Marfan syndrome, especially acute aortic dissection, hypertrophic cardiomyopathy. Other indications are like pheochromocytoma, cyanotic spills, glaucoma, migraine prophylaxis, essential tremors, variceal bleeding prevention, anxiety disorders, possible okay, that is a minor indication. Controversies with the beta blocker therapies. The role of beta blockers in management of heart failure. There is paradigm shift. What was once considered a contraindication has now become a class one indication. One person who worked a lot against all the odds is Dr. Finn Wangstein. The role of beta blockers in the management of hypertension. So there are two types of beta receptors. First is located in heart and kidneys. Those are type 1 beta receptors. Then beta 2 receptors are located in lungs, in gastrointestinal tract, liver, uterus, vascular smooth muscles, and skeletal muscles, also present in the heart. These are the two main receptors. There is another third beta 3 receptors as well there. They have got a limited action. They're located in the fat cells, present also in vascular smooth muscles, mediate the vasodilation induced by the nitric oxide in response to the vasodilating effect of the beta blocker like nebivolol. So what are the organ effects of beta blockers? As we can see here, uh, uh, there are two types of beta blockers. One is non-selective, like propranolol, timolol, etc. So they reduce the heart rate, decrease the contractility, decrease AV conduction. From kidneys, there is renin secretion is reduced, so it helps in hypertension prevention. On eyes, it reduces the aqueous humor production. And there are few selective beta blockers. They especially work on the limited, especially in the heart and the vasculature only. So these are bisoprolol, atenolol, and metoprolol. So those are beta 2 actions. Beta 2 actions, how do they work? It basically it works on the vascular smooth muscle cells contraction and reduces the peripheral vascular resistance as well the airway resistance. So let us look at the risk factors for heart failure. Increased sympathetic overactivity. So beta 1 adrenergic receptor CMP mediated effects, enhanced excitability and contractility that leads to tachycardia, tachyarrhythmia induction, myocardial hypertrophy remodeling, accelerated cellular death, and release stimulation. So by blocking beta 1 receptors, we all reduce all these effects. Beta 2 adrenergic receptors, they cause CMP mediated effects like tachyarrhythmia induction, pre-systolic norepinephrine release stimulation, and alpha 1 adrenoceptor receptors vasoconstriction, tachyarrhythmia induction, myocardial hypertrophy remodeling, and sodium and water retention. So risk factors for the heart failure is basically increased sympathetic overactivity. So all these things can lead to worsening of the heart failure. So when we use beta blocker, it probably addresses all these problems. Beta 1 selectivity of various beta blockers. So when we look at the various beta blockers, uh, beta 1 selectivity increases as we go to the bisoprolol, lesser is atenolol and then metoprolol. And as everyone knows, propranolol is non-specific beta blocker. Selective beta 1 blockade and reduced sympathetic activity in heart failure. Sympathetic activation leads to basically beta 1 receptor, all three kinds of receptor activation. Metoprolol blocks, especially metoprolol, bisoprolol, nebular blocks only beta 1 receptors, and carvedilol blocks all these three receptors. So we know heart failure in India. This is basically different studies which are showing the incidence of prevalence of the heart failure in India. Meta-analysis of the beta blockade improve the survival in elderly heart failure patients. So different trials done in different countries, they have shown that beta blockers improve the survival in heart failure. This is the comparison between ACE inhibitors, ARBs, beta blockers, aldosterone antagonist. So we can clearly see that there is significant benefit of beta blockers in reduction of mortality. Then NNT for mortality reduction is very fair with the beta blockers. So hospitalization for the heart failure is as well reduced with the beta blockers quite significantly. So when we look at the heart failure, beta blockers should be considered as a mainstream in the treatment. So this is about the reduced mortality in hospitalization for heart failure, and this comparison with placebo and metoprolol, there is significant Benefit of metoprolol. Improved survival with carvedilol in patients with severe chronic heart failure. So placebo versus carvedilol, it as well shows significant benefit with a beta blocker. So what are the contraindications for beta blockers? Uh, Compelling contraindications are asthma, very high grade of synovial or AV blockade, or bradycardia. Okay, so another possible contraindication can be severe metabolic syndrome, glucose intolerance, and uh, active people. So let us look at the guidelines. 2018 ESC and ESH hypertension guidelines recommendation in hypertensive patients with heart failure. BP lowering treatment should be considered if the BP is more than 140 and 90. That is 2A uh, level B evidence in patients with hospital heart failure patients with low ER, low EF. It is recommended that BP lowering treatment comprise just an S inhibitors or ARB and a beta blocker and diuretic and or MRA if required. So that is a class 1 level A indication. So very high evidence. CCBs can be added only if the BP control is not achieved with the AC emitters and beta blockers. In patients with preserved EF with heart failure, BP treatment threshold and target value should be the same as of patients with low EF. Because no specific drug has proven its superiority in all major agents can be used. In all patients with LVF, it is recommended to treat with RAS blockade, that is ACE inhibitors or ARPs, in combination CCBs or diuretics. Systolic BP should be lowered in the range of 120 to 130. HA 2017 heart failure guidelines, what they say about the beta blockade. Beta blockers are for heart failure with preserved ejection fractions. Uh, the use of beta blockade agents is ARBs in patients with hypertension is reasonable to control the blood pressure in patients with heart failure with preserved ejection fraction. And then reduced EF beta blockers are recommended in patients with asymptomatic LV systolic dysfunction and a history of myocardial infarction in older, in order to prevent or delay the onset of heart failure or prolonging life. So there is definitely mortality benefit as well as quality of life, and life has been improved with the beta blocker. So in summary, heart failure is a global burden with hypertension as an root cause. And beta blockers are important in treating heart failure, have proved useful in reducing the likelihood of progression through a continuum of heart failure. They should be included in the therapeutic regimen of patients with with symptomatic LVSD patients to prevent progression to symptomatic heart failure to improve the survival. Evidence-based beta blockade therapy, especially bisoprolol, carvedilol, metoprolol, succinate is mainstay of the treatment in all symptomatic patients with heart failure. Thank you very much.
Thank you, sir. Thank you very much. On behalf of IPCA, given a thanks, given a particularly for Abhishek, given a valuable time, and I thanks particularly for Chandrakant Upadhyay sir also given a valuable time. Thank you very much, sir. This is our session, particularly for Experts Outlook series number 2. The today's topic of beta blocker in hypertension with heart failure is over. Thank you very much, sir.